Hello everyone, I welcome you to CHH 702, the course titled Child Growth and Development. Today we are laying the foundation for the course by clarifying what we mean by growth, development, and developmental milestones, and by considering why these concepts matter in public health. Although these words are familiar, they are sometimes used as if they mean the same thing. They do not. A child may gain weight and height while having difficulty in language or social interaction. Conversely, a child may be physically small yet demonstrate appropriate progress across developmental domains. The subtitle on this opening slide tells us the 4 areas we shall be covering: the purpose of the course, the basic concepts, the determinants of growth and development, and their public health relevance. I shall move from the simplest definition to the more applied questions. We shall not stop at asking what growth or development means. We shall ask how each is assessed, what shapes the child's trajectory, how concern is recognized, and what a public health practitioner should do with the information. This is an MPH lecture, so throughout this session, I shall move between individual child and the population. At the individual level, we are concerned about whether a particular child is progressing appropriately. At the population level, we asked whether a large group of children are being denied the conditions needed to thrive, whether inequalities are widening, and whether programs are producing measurable benefits. Let us begin with a question that brings those two levels together. As we proceed, please keep the whole child in view. We shall consider the biology, but we shall also consider caregiving, nutrition, stimulation, education, household resources, health services, and the wider policy environment. By the end of this lecture, I want you to be able to recognize what should be measured, what should be observed, what may signal concern, and where public health actions can change a child's trajectory. The purpose is not simply to memorize age-linked facts. It is to understand how to help children survive, how to help them develop and thrive in any environment. Let us begin with simple but important question. What must we observe, measure, and change so that every child can thrive? You will notice that I have used these different verbs. We measure physical growth, we observe functional development, and we change the conditions that prevent children from reaching their potential. If we focus only on weight and height, we may miss the problems in communication, learning, movement, or relationships. If we focus only on developmental skills, we may miss malnutrition, chronic illness, or an unhealthy growth trajectory. On the right-hand side of this slide is the word thrive. Around that idea are 2 major actions: measure and interpret. Measurement gives us information, but interpretation gives it meaning. A weight of 10 kilograms, for example, cannot be interpreted properly without knowing the child's age, sex, length or height, previous measurement, and clinical context. In the same way, a child using only a few words cannot be understood without considering age, hearing, comprehension, opportunities for communication, and progress in other domains. The sentence at the bottom of this slide connects the child's trajectory to the family, services, and the society. That is the public health perspective that I would like you to keep focusing on. Children develop within relationships and systems, not on their own. Therefore, when a child is not thriving, our question should not be limited to what is wrong with the child. We should also ask what conditions around this child may be restricting progress, and what can we change? Please think briefly of a child you have encountered whose growth or development caused concern for you. What first alerted the family or health workers? Was it measurement, a missed ability, a change in behavior, or a comparison with other children? Those answers illustrate why public health needs a broader perspective. Thriving is more than being alive or free of obvious disease. It includes adequate physical growth, increasing functional competence, emotional security, opportunities to learn, and supportive relationship. The central purpose of this course is to help us move from observation to action. First, we learn to recognize expected problems of growth and development. Second, we learn to detect deviations early. Third, we explain those deviations by connecting possible causes at the child, family, community, and health system levels. Finally, we use that understanding to design services, programs, and policies. The four cycles on this slide form a logical sequence. The recognition comes first before we need a clear picture of what is expected. Detection follows because we compare observation with expectation. Explanation comes next because a deviation is a finding, not yet a cause. Action comes last, but action must be planned from the beginning. If we detect a problem without a pathway from assessment and support, detection alone may not improve the child's life. You will notice also that the arrows move in one direction, but practice includes feedback. After we have acted, we measure again. We ask whether the child improved, whether the family could use the service, whether the program reached those at greatest risk, and whether unintended problems emerge. Therefore, the full public health cycle is to recognize, detect, explain, act, and evaluate. This sequence is important. A measurement without interpretation does not help the child. Detection without a clear response pathway may simply label a problem. Explanation without intervention may remain an academic exercise. Public health practice brings these parts together. For example, if routine monitoring shows growth faltering, the response may require more than feeding advice to the parents. We may need to consider infection, feeding practices, household food insecurity, caregiver well-being, access to healthcare, and the quality of counseling. The course, therefore, asks us to connect clinical observations with population surveillance, prevention, early intervention, and equity. These are four main learning outcomes for today's lecture. By the end of this lecture, you should be able to define growth, development, and milestones accurately, distinguish intrinsic from extrinsic influences, recognize expected pattern and meaningful deviations from normal, explain why early detection can improve outcomes, and apply selected developmental theories to public health practice. Let us unpack the five outcomes one by one. To define the concept means that you should be able to explain their differences without confusing size with function. To distinguish intrinsic and extrinsic influences mean that you can identify factors within the child and factors in the surrounding environment while recognizing their interactions. To recognize pattern and deviation means that you look at trajectories rather than isolated observations. To explain early detection means that you understand the opportunity for timely support. Finally, to apply Paget and Erickson means that theories should change how we communicate and design programs. These are observable learning outcomes at the end. So at the end, I should be able to give you a short case and hear you reason through it. If you can only repeat a definition but you cannot decide what a measurement or how to respond, the learning is then incomplete. Therefore, I encourage you to treat these outcomes as a self-assessment rather than a list of things to read and be forgotten. At the end of this session, ask yourself whether you can explain each one in your own words and apply it to realistic child health problem. Which of these outcomes currently feels less familiar to you? Think about it. Keep that item in mind as we proceed. The outcome also show progression of the lecture. We begin with definitions, move to determinants and patterns, then consider recognition, theory, and application. This slide shows the wider course journey. We begin with foundation concepts and determinants. We then move to the assessments, such as anthropometry, growth charts, developmental observation, and screening. After that, we examine major challenges, including undernutrition, underweight, and obesity, the developmental disorders, and other threats to healthy trajectory. We then consider interventions and policy before ending the research and innovations. The 5 blocks represent the structure of wider course. Foundation answers, what are we talking about? Assessment answers, how do we observe and measure it? Challenges answers, what threatens healthy progress? Response asks, what can individual service and policy do? Inquiry asks, what remains uncertain and how can research improve practice? Each block depends on the one before it. Each block depends on one before it. When you later encounter growth charts, screening instrument or program indicators, return to this structure. A tool is only useful when it measures a clearly defined concept, identifies a meaningful problem, and connects to an appropriate response. With that map in mind, we can now define the 3 terms that anchor the course together. The order is deliberate. We cannot interpret a growth chart correctly without understanding what growth represents. We cannot select a developmental screening approach without knowing the domain we are assessing. We cannot design a program until we have identified the determinants and the point in the pathway where change is possible. Please also note that each module should inform the next one. They are not isolated topics. The aim is to build a coherent public health understanding from the basic concepts to measurement, interpretations, and action. Now let's talk about growth, development, and milestones and answer different questions. Okay, now let's make a distinction among the core concepts. Growth simply refers to the quantitative change in body size over time. We commonly assess it through weight, length or height, head circumference, and other anthropometric measurements. Development refers to qualitative and progressive change in function, skills, behavior, and adaptation. It includes how a child moves, communicates, thinks, solves problems, regulates emotion, and relates to others. Milestones are age-linked abilities or behaviors that provide practical reference points for observing development. Look at these 3 questions written under the headings. Under growth, the question is, how much has body size changed? Under development, it is, what can the child do? Under milestones, it is, when are key abilities expected? These questions prevent us from using the term loosely. Growth is commonly expressed numerically. Development is observed through increasingly complex abilities and behaviors. Milestones are reference points within the developmental process. Milestones should not be treated as the whole development. They are selected markers that are easy to recognize, such as sitting, walking, and combining words together. Between one milestone and the next, a great deal of gradual learning is taking place. We should therefore ask not only whether a milestone is present, but also whether the child is making progress and how the child performs the skill. A helpful way to remember this difference is to ask three questions. Growth asks, how much has body size changed? Development asks, what can the child do now? Understand or manage? Milestone asks, when are particular disabilities generally expected to emerge? These concepts are related but are not interchangeable. Likewise, small body size does not automatically mean that all developmental delays are delayed. Good assessment consider both physical trajectory and functional progress. Growth should be understood as a trajectory, as you can see from the graph. One measurement tells us the child size at one point in time, but repeated measurement shows direction and velocity. A child may be small and continue along a stable trajectory, but another child may remain within a broader reference range, yet show a concerning downward crossing of growth curves. The pattern often gives more useful information than an isolated value. The graph rises from left to right, as you can see, because body size generally increases with age. But the most important message is not that all children follow one straight line. Real growth varies in tempo, and reference charts describe distribution rather than a single compulsory pathway. The plotted points represent repeated contacts and the measurement. Joining them allows us to see direction. The steepness of the line gives an impression of velocity, while a flattening or downward movement prompts us to raise concern. Whenever a point looks abnormal, first check the foundation. Was the scale calibrated? Was the child weighed with appropriate clothing? Was length or height measured with correct equipment and positioning? Was age recorded correctly? Plotting error on the chart can create false concern, while careless measurement can conceal genuine faltering. Only after confirming data quality should we interpret biological and environmental causes. This is why accurate measurement, correct age, appropriate reference standard, and serial plotting are essential. A plateau in weight, a decline in expected velocity, a disproportionate change may signal inadequate intake, infection, chronic disease, feeding difficulty, or another problem. We should first confirm the measurement and plotting, because poor technique may create a false pattern. Once confirmed, we then interpret the trajectory alongside the clinical history, examination findings, diet, development, and the child's environment. Growth monitoring is therefore not simply a weighing and recording exercise. It is measurement linked to interpretations and actions. Occurs across several connected domains. The main domain includes gross motor abilities, such as sitting and walking, and fine motor abilities, such as grasping and manipulating objects. Language includes both understanding and expression. Cognitive development includes attention, memory, learning, reasoning, and problem solving. Social emotional development includes attachment, interaction, self-regulation, play, and relationship. The child is placed at the center because the domain belongs to one developing person. Motor development includes posture, movement, and manipulation. Language includes receptive language, what the child understands, and expressive language, what the child communicates. Cognitive development includes learning, memory, attention, and problem solving. Social development includes attachment, interaction, play, emotional regulations, and relationships. The connecting lines show interdependence of these domains. A child with hearing impairment may show effects in language, social interaction, and learning. A child with severe motor limitation may have fewer opportunities to explore, even when cognitive potential is strong. A nurturing caregiver can support several domains simultaneously through responsive talking, playing, and encouragement. This is why assessment should describe strengths as well as difficulties across full profile. These domains are separated for assessment, but the child does not experience them separately. Progress in one domain can support progress in another. For example, improved mobility gives the child new opportunities to explore. Exploration supports cognition. Language helps the child communicate needs and participate socially. Emotional security supports learning. Conversely, difficulty in one area may restrict opportunities in others. Therefore, when concern arises in one domain, we should look at the whole developmental profile rather than assume it is an isolated problem. We should also consider vision, hearing, health, caregiving, and environmental stimulation because these can influence several domains at once. Milestones are useful because they organize observations around abilities that commonly emerge during particular age period. The example on this slide are appropriate. Sitting with support and babbling around the middle of infancy. Independent walking and first word during the second year, and running, combining words, and pretending play as the child approaches 2. These examples help caregivers and professionals notice progress and possible concerns. Let us read the table by rows. At approximately 6 months, the example includes sitting with support, babbling, and active engagement with people and objects. Between 12 and 15 months, many children walk independently, use early words, and imitate familiar actions. At around 2 years, running, using stairs will help. Combining simple words and pretend play becomes increasingly evident. These are teaching examples, not a substitute for approved developmental surveillance and screening standard. The last sentence under the table in this slide is the safeguard. Interpret milestones with history, examination, context, and repeated observation. We need to know whether the child was born preterm, whether vision or hearing was impaired, whether illness has interrupted progress, and whether the child has opportunity to practice the skill. We also listen seriously to caregiver concern because caregiver observe the child across many situations over time. However, milestones are not rigid deadlines and normal variation do exist. A missed milestone does not by itself establish a diagnosis. We must confirm the child's age, obtain a careful history, observe the skill directly where possible, assess other domains, and consider cultural and environmental opportunities. Ask yourself, does a child who has not walked independently at a particular birthday automatically have a developmental disorder? The answer is no. It is a signal for closer assessment rather, and not a diagnosis. More concerning pattern includes delay across several domains, loss of previously achieved milestone or ability, abnormal neurological sign, or persistent parental concern. A child's trajectory reflects continuous interaction between the biology and the context. At the center of this child's genetic inheritance, health, sensory function, hormonal regulation, and biological maturation. Around the child is the immediate care environment, nutrition, responsive caregiving, protection, play, language exposure, and opportunities to learn. Beyond the family are social and system conditions, including income, education, housing, food security, health service, and community safety and policy. The diagram you are seeing is organized in 3 nested layers. The innermost layer is the child biology, the genes, health, and hormonal influences. The next layer is the family and care environment, nutrition, responsive caregiving, and stimulation. The outer layer is the wider social system context, income, education, services, and policy. The nesting shows that the child is not separate from these environments. Each outer layer shapes what is possible within the inner layer. This model also helps us to locate intervention. A health condition may require clinical treatment. Feeding difficulty may require caregivers counseling and practical support. Household food insecurity can require social protection and community action. Poor service coverage may require workforce, financing, or policy change. Effective child health programs often combine actions across more than one layer. The important point is that these layers interact. We should not ask whether growth and development are caused by nature or nurture, as if only one can be true. Genetic potential is expressed within an environment. Chronic illness may restrict growth as well, but access to timely treatment can reduce the effect of that chronic illness. Poverty may increase the risk through food insecurity, caregiver stress, and limited access to service, but social protection and high-quality primary care can provide buffer for this. Public health has leverage precisely because many contextual influences are modifiable, even when biological vulnerability cannot be removed. Where we can group influences broadly as intrinsic and extrinsic factors. Intrinsic factors arise within the child and include genetic inheritance, biological sex, maturation, hormonal regulation, congenital conditions, and chronic illness. Extrinsic factors arise from environment and include nutrition, infection, exposure, caregiving, stimulation, household resources, education, health service, and the physical and social environment. This slide places intrinsic and extrinsic factors side by side with the interaction beneath them. That word is crucial. Intrinsic factors include inheritance, maturation, hormone regulation, and healthy condition. Extrinsic factors include nutrition, infection, exposure, caregiving, social environment, social circumstances, education, and health services. We separate the categories for thinking, but in real life, they operate together. For example, a child with congenital heart disease has an intrinsic health condition that may affect feeding and growth. The outcome will also depend on diagnosis, access to specialist care, family resources, infection prevention, and nutritional support. The same intrinsic condition may therefore produce different trajectory in different environments. Public health seeks to reduce avoidable disadvantage around biological vulnerability. So, you must always pay attention. This distinction is useful, but it must not suggest that the two groups operate independently. Consider height. Genes contribute to child growth potentially, but nutrition, recurrent infection, chronic illness, and access to care influence how fully the potential is realized. Okay? Consider language development. Neurobiological capacity matters, but hearing, responsive interaction, exposure to language, and opportunities for communication also matter. Therefore, when a child is not following an expected trajectory, we should avoid blaming either the child or the caregiver. We should assess interacting factors and identify which ones are modifiable. Growth and development are population health signals. Growth and development are not only clinical concerns, they are population health signals. Through surveillance, we can monitor pattern of stunting, wasting, overweight, obesity, and developmental risk. Identify geographical and socioeconomic inequalities and detect changes over time. Through early detection, we can identify children who need closer assessment or support before difficulty becomes more severe and secondary disadvantage accumulate. The 4 boxes you are seeing show 4 public health uses. Surveillance tells us what is happening and to whom. Early detection identifies risk before difficulty accumulates. Program design uses knowledge of determinants to select appropriate actions. Evaluation tells us whether those actions achieve the intended result. These functions are related but require different questions and indicators. A surveillance system may show high prevalence of stunting, but the findings alone should not tell us which intervention will work. We need causal understanding and local assessment. Likewise, a program may distribute supplements, but evaluation must examine coverage, correct use, equity, and outcome, not merely the number of items distributed. Growth and development indicators become powerful when they support decisions rather than simply fill reports. The same information guides program design and evaluation. If growth fostering is concentrated in particular communities, we examine food security, infection, water and sanitation, service coverage, and caregiving support. If developmental concerns are identified but referrals are not complete, the problem may lie in the service pathway rather than the screening tool. We can then measure whether an intervention improves coverage, referral completion, or outcome. The public health value, therefore, lies in the full chain: measure, interpret, response, and evaluate. Note that the word normal is a pattern interpreted within age and context. The word normal must be used carefully. It does not mean that every healthy child achieves every ability on exactly the same day, or they follow an identical growth curve. No. Expected variations can be broad. What matters is whether the pattern is plausible for the child's age and context, whether progress continues, and whether there are concerning associated findings. The 4 numbered boxes describe a careful decision process. Box 1 reminds us that healthy variation exists. Box 2 identifies a concerning signal such as a plateau, regression, or marked deviation. Box 3 requires assessment, confirm the measurement, and integrate history and examination. Box 4 is the response, which may range from counseling and follow-up to investigations and treatment or referral. The arrows present us from jumping directly from variation to diagnosis. They also prevent us from stopping at concern. A concern should lead to an appropriate next step. The intensity and urgency of that step depends on the pattern, associated findings, the child's age and vulnerability, and the available evidence. When we observe a plateau, regression, or marked deviation, we should follow a disciplined sequence. First, confirm the observation or measurement. Second, integrate history. Third, consider the child's environment and opportunity. Fourth, decide the appropriate response. Reassurance and follow-up, counseling, further assessment, investigations, and treatment or referral. This approach prevents two errors. The first is over-labeling LD variation. The second is dismissing a meaningful signal until valuable time has been lost. The purpose of standard and milestones is to support judgment, not to replace it. That we need to act when the pattern of growth or development changes, stalls, or reverses. Three pattern deserves particular attention. Growth fluttering occurs when expected weight or height gain slows, plateaus, or decline. Developmental delay means that an expected ability is not emerging within a reasonable period, or that progress is substantially behind expectation. Regression means that a child loses a skill that had previously been acquired. Regression is especially important because it may indicate a neurological, metabolic, psychosocial, or other serious problems and requires prompt assessment. The downward arrows over faltering represent a trajectory that has slowed or fallen. The dot over delay represents an ability that is not emerging or as expected. The curved backward arrow over regression represents loss of acquired skill. These are different phenomena and should be described accurately. A child who has never acquired a skill is delayed in the area. A child who acquired it and then lost it has regressed. The instruction at the bottom of this slide: verify first, then assess the child, family and environment, protect scientific and clinical judgment. We should not interpret a poor measurement as disease, but neither should we repeatedly postpone actions when a genuine adverse pattern is presented. Documentation of onset, sequence, associated symptoms, and contextual changes can help clarify the problems. Before acting, verify the pattern. Was the age correct? Was the measurement technically sound? Has the caregiver had an opportunity to observe the skill? Then assess the child broadly: nutrition, illness, hearing, vision, neurological function, interaction, safeguarding, and care environment. Detection creates time for effective support. The process begins with observation, routine growth monitoring, developmental inquiry, caregiver concerns, and professional observation. Screening may then help identify children at increased risk, but screening is not the same as diagnosis. Children with concerning findings require assessment to clarify the nature of the problem, possible causes, strengths, and needs. This pathway has 4 stages. Observation includes routine growth measurements, developmental inquiry, caregiver concern, and direct observation. Screening uses a structured tool or a defined threshold to estimate risk. Assessment goes deeper to clarify the nature, severity, and possible causes of the concern. Intervention responds to the identified needs and includes follow-up. Please remember the distinction between screening and diagnosis. A screening result indicates that further assessment may be needed. It does not prove that a disorder is present. Screening programs require informed communication so that families understand the meaning of the result. They also require referral capacity because identifying risk without accessible assessment and intervention may widen frustration rather than improve outcome. Intervention should be linked to what the assessment shows. It may include feeding support, treatment of illness, hearing assessment, developmental stimulation, therapy, caregiver coaching, social support, or referral. Follow-up is essential because we need to know whether the child is improving and whether the family can access the recommended service. Okay, a screening program without a functioning referral and follow-up pathway may create anxiety without benefit. Public health planning must therefore strengthen the entire pathway from observation to intervention and not simply increase the number of children screened on the field. Let us apply the concept we have learned. Consider a 3-year-old child who is shorter than expected, speaks only a few words, and live in an household facing food insecurity. Please do not jump immediately to diagnosis. First, think individually for about 1 minute. What information or measurement needs confirmation? Which intrinsic and extrinsic factors may be relevant? What immediate actions will be appropriate? These slides give us 4 minutes and 3 questions. The first ask, what needs confirmation? We need accurate age, length or height, previous growth measurement, the meaning of few words, comprehension, hearing, progress in other domains, and relevant health history. The second ask, which intrinsic and extrinsic factors matter? We should consider health conditions and sensory function alongside diet, infection, responsive interaction, food insecurity, and service access. The third ask, what immediate actions are appropriate? An appropriate response begins with assessment rather than a premature label. It may include confirming growth status, dietary and clinical review, hearing and developmental assessment, practical feeding advice, connection to nutrition or social support, and a clear follow-up plan. I will now allow 1 minute for individual thoughts, 2 minutes for paired discussion, and 1 minute to hear selected responses. Now, discuss your answer with the person beside you for 2 minutes. Finally, we shall take a few responses from the class after this lecture. Let's go on now. The case cannot be addressed at only one level. At the level of the child, we confirm age and anthropometry, review the growth trajectory, assess nutrition and illness, examine development across domains, and consider hearing, neurological findings, and safeguarding. At the family level, we explore diet, interaction, stressor, decision making, and available resources, then provide practical counseling and support. The third column or the 3 column organize the response. Under child, we confirm anthropometry and age and assess nutrition, illness, hearing and development, and safeguarding. Under family, we explore diet, interaction, stressor, resources, and provide practical counseling. Under system, we link the family to primary care, nutrition, developmental services, and social protection and arrange follow-up. None of this column is sufficient alone. Okay, a clinical referral that ignores transport costs may not be complete. Advice to provide a diverse diet may be unrealistic without attention to food insecurity. Social assistance alone may may miss a medical course. Integration means that the plan is clinically sound, feasible for the family, and supported by available services. At the system level, we connect the child and family to appropriate services: primary health care, nutrition, support, hearing and developmental assessment, social protection, and referral where necessary. We also arrange follow-up. The information provided in this case is not sufficient to establish diagnosis, and that itself is an important lesson for us all. Public health and clinical responses should be comprehensive without pretending that uncertainty has disappeared. Integration prevents fragmented care. For example, treating nutrition while ignoring communication or recommending therapy that family cannot access will not be appropriate. Now let us discuss this topic in the context of Nigeria community and primary health care. In Nigeria, the effectiveness of early identification depends heavily on caregivers, communities, and primary health care. Caregivers need practical knowledge of expected progress and warning signs, but awareness alone is insufficient if services are inaccessible or unresponsive. Primary care workers need accurate measurement skill, the ability to ask about developmental progress, appropriate counseling tools, and clear referral pathway. The pathway begins with caregiver's knowledge, because caregivers are often the first to observe the child. It then moves to primary care, where staff measure, screen, and counsel. The next step is a referral network that can assess and intervene. The final box is population policy, which addresses structural risk such as poverty, food insecurity, unequal access, and weak services capacity. The arrows shows continuity. If any link is broken, benefit may be lost. Awareness without assessment or accessible primary care is insufficient. Screening without referral capacity is incomplete. Specialist care without follow-up at the community level may not sustain the care. Policy should therefore support an integrated pathway and monitor whether children from disadvantaged group can move through the care provided successfully. Okay, referral services must also be reachable and coordinated. Where specialist services are limited, task sharing, caregiver mediated support, community follow-up, and stronger links between health, education, and social services may be important. At population level, policies addressing poverty, food insecurity, maternal education, disability inclusion, and access to quality care influence child or children's trajectory. Integrated child health platform provide opportunity for growth monitoring, counseling, and early recognition, but implementation quality matters. Equity improves when detection is connected to accessible, respectful, and responsive services within the social context of the environment. Now, let us consolidate this lecture in just 5 points. First, growth is quantitative change in body size, while development concerns function and is multi-dimensional. Second, trajectory matters more than an isolated observation. Third, biology and environment interact continuously. Fourth, growth faltering, developmental delay, or regression requires structured assessment rather than assumptions. Fifth, public health converts early recognition into equitable action. The first point distinguishes the concept. The second tells us follow change over time. The third rejects a false choice between biology and environment. The fourth tells us how to respond to adverse pattern. The fifth combats individual recognitions with equitable public health actions, together with the 5 points for a compact framework. And for the rest of this course, we shall be looking into each of these in greater detail. I would like you to explain each point to yourself using an example. For trajectory, think of several weight measurements. For interaction, think of genetic potential expressed under different nutritional conditions. For early action, think of a caregiver concern that leads to assessment and support. Retrieval in your own word helps move the idea from recognition to usable understanding. We end this lecture. Remember 3 instructions. See the old child, follow the trajectory, and act early. Seeing the old child means considering physical growth, developmental function, relationships, and context together. Following the trajectory means using repeated observation rather than relying only on one single measurement or comparison. Acting early means linking recognition to assessment, support, referral, and follow-up while there is still a wider opportunity to improve outcomes. The closing slide here has 3 short commands. See the old child mean do not reduce the child to weight, diagnosis, or one missed milestone. Follow the trajectory means look at progress over time and across domains. Act early means connect recognition with support while opportunities for benefit is greatest. These are clinical principles, but they are equally principles for program design and policy. Before we finish, I want each of you to identify one change you will make in a child health program. It may be better measurement quality, routine developmental inquiry, more responsive caregiver counseling, a functional referral pathway, improved follow-up, or stronger social support. The important thing is that your proposal change connects observations to actions. Okay, my final question is this: what is one change you will make in a child health program after this lecture? Thank you for your attention and participation. In the next part of the course, we shall build on the foundation by examining how growth and development are assessed more systematically. Thank you.